Hello everyone. Thank you for joining us today. My name is Luke. I'm one of the education directors at SUPTA. Can I just get someone from the audience just confirm that you can hear me and see me and everything sounds okay? If you just a thumbs up in the chat or whatever. Guys, can you? Yeah, perfect. Okay, great. We'll make a start. So, as I said, my name's Luke. I'm one of the education directors at SUPTA. This week we're focusing on upper limb TNO. And we're excited to have you all with us. Today I'm joined by Amin Sahani, who will guide you through the clinical conditions of the upper limb. So Amin is a final year medical student from the University of Central Lancashire. To make sessions as engaging as possible, we'll be releasing polls throughout, so they're completely anonymous, and we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share a feedback form, and if you complete this, you'll receive a certificate of attendance and exclusive discount codes for Teach Me Surgery and Pass the MRCS. Additionally, this session is being recorded. The recording and slides will be shared on our medal page a couple of hours after the session, so be sure to keep an eye out for that. We're also excited to share that an exclusive question bank and other resources will be available on our learning portal, so be sure to check out our website to access them. If you create a free membership account with us, you'll automatically receive a discount code for 10% off the Geeky Medics Anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all our attendees. So 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code we'll provide. The more sessions you attend, the higher your chances of winning. So be sure to stay to the end of today's session and attend as many of our other sessions as well. And just finally, before we begin, we'd like to thank our partners, which are the Royal College of Surgeons England, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. So without further ado, I will pass over to Amin.
Thank you very much, Luke, for the introduction. I'm just going to share the slides. Sorry, guys, I don't have access to the chat, but if you pop the questions, Luke will be able to read it out loud later on. So thank you again, everyone, for joining. We're just focusing on upper limb conditions today. We're just going to whiz through a lot of the conditions. So it's going to be a fast paced session. And then if you have any questions, again, pop it in the chat. Try to answer as best as we can. So here are our partners. This is learning objectives. So the first case, a 32-year-old male with a history of epilepsy presents to A&E after experiencing a generalized tonic-clonic seizure. He complains of a severe right shoulder pain and he's holding his arm in a slight adduction and internal rotation. Examination reveals a loss of the normal shoulder contour with prominent acromion. There is a reduced range of motion and no obvious neurovascular compromise. So the question is, what is the most likely type of shoulder dislocation in this patient? A, anterior, B, posterior, and then C, inferior, I think. Luke is just gonna, oh, he has already put the question. We're just gonna give it a few seconds. If you could, guys, if you could participate, we have like 10 responses so far.
Amin, can you see the results?
Yes, now. So it's 50-50 now. The correct answer is posterior, although anterior dislocation are most common. 90% of them are 90% of shoulder dislocations tend to be anterior. However, with the history that patient is presenting with and the signs and symptoms described, it's more likely to be a posterior. So we're just going to go through the X-ray of anterior and what we find, and basically what are the things we should be looking for. So in an anterior dislocation, with any dislocation, what we do is we get an X-ray initially, and then we see if there is any neurovascular compromise, if there's any fractures that we can see on X-ray, or neurovascular compromise on examination. Um, if not, then we would proceed with an attempt to put the shoulder back, and then we would try to get another X-ray to confirm that we have restored the normal anatomical position. So on the left, we have an X-ray of an anterior dislocation. As you can see, the humeral head is dislocated anteriorly and rests under coracoid process. Whereas on the posterior side, we got a commonly known light bulb on a stick sign. As I put the light bulb here as well, you can see that the edges of the humeral head is sort of looking like a light bulb. Um, and this is a sign of posterior dislocation. So the humeral head does not appear, uh, sorry, it is internally rotated, and the contour, again, as I mentioned, it looks like a light bulb, and that's why it's called light bulb sign. So, as I mentioned, 90% of the shoulder dislocations are anterior dislocations, and the position you would find the arm in is internally rotated and abducted, and you might have a silhouette flattened, silhouette with a prominent acromion, and the 10% of them which aren't anterior are usually posterior, and where you find the arm is fixed, internally rotated, and adducted. And this commonly happen in two situations, one of them being in people who have epilepsy. So when they have a fit, they sometimes tend to get their arm dislocated. Now, many of them are able to just pop it back in, so they would do that, and they wouldn't have to come to the A&E. But sometimes it becomes really difficult for them to do that. They won't be able to put it back in, and then they would come to A&E perhaps to get it checked and put it back in. And the other scenario where you get posterior dislocation is commonly known for is electrocution. So again, similar mechanism to seizure, you often get a posterior dislocation. And there is another type of dislocation which is an inferior dislocation, uh, where the arm is in an abducted position, and sometimes the arm is held above like that. Again, it's not as common as anterior or posterior. And the management with shoulder dislocations, what we do is we try to give a good painkiller, make sure the patient is at ease as much as you can, and then you take a history, you find out what's been going on. Um, first-time dislocations often result from high-impact injuries. Um, but if they've already had many dislocations, they might have instability of the shoulder ligaments, and that may put them at increased risk of having a shoulder dislocated again. Sorry, keep pushing it. So back to the slide. On examination, you just have to check the neurovascular exam. So you do a neurovascular examination, you check for the nerves, make sure they have sensation, if they can move the fingers distally. Um, this is just to make sure that there is no nerve injury. Axillary nerve palsy may result from sort of dislocation, and you may get numbness in the regimental badge area where you find the deltoid. So if there is a numbness over there, you should suspect an axillary nerve injury. And what you often find is that the patient is not able to demonstrate any external rotation in posterior dislocation. So what you do is with the management, as I mentioned, you get an X-ray before reduction, minimum 2 views. And then once you're happy that there's no injury to the nerves, there's no fractures, you can attempt at relocating the joint. And again, you get an X-ray to make sure everything is fine. There are different techniques where you can reduce the shoulder. So the closed reduction of anterior shoulder does not require application of like huge force. It's like a slow movement, sort of like in massages that you give to the patient and help the shoulder to just pop back in by itself. Uh, it is worth knowing if a couple of these in your head, just in case one didn't work. It's common that you might start with one technique and then you find it it's not working, and then you might have to switch to a different technique. Um, yep. So just as an example, we're going to go through poker technique. In this technique, what you do is you hold, if it's the right hand that is dislocated, you hold the elbow with your right hand, and then you hold the wrist with your left hand. And then what you try to do is to externally rotate the shoulder. So by applying the force with your left hand, um, and then you try to keep the elbow at the same position. And then what you do is you try to bring the after you've applied the external rotation for about 70 to 90 degree and ask the patient if they're feeling the resistance. You ask them to relax as well. And then what you try to do is to move the arm a bit anteriorly and you lift it off the patient's chest. And you may bring it into the chest or you may just bring it a little bit up. And then that should pop it back in. And then if not, you do the last stage, which is the shoulder is rotated internally to bring the hand on the opposite side, and that should put it back in. Again, the shoulder may the reduction may happen at any stage. It doesn't have to be. You don't have to go through 1 to 4 for it to get reduced, but you may do all of it, and the shoulder may still not be reduced, and that's where you sort of move on to a different technique. And many of these techniques are often performed by not just one clinician. It's like multiple clinicians taking care of different things. One might be the pain management, sedation, things like that, and the other clinician would take care of the technique itself. Now, we have another case of a stiff shoulder. So I'm just going to read it out loud for you guys. 44-year-old female patient was walking the dog when she slept on a frozen path and landed on her left shoulder. She developed a persistent aching in her shoulder and later attended urgent care. A few days later, she is still having difficulty washing and dressing despite having no pain. Past medical history of diabetes and is on insulin. On examination, there is no signs of obvious swelling or deformity on palpation. She has no tenderness. On palpation, she has no tenderness. However, on movement, she has markedly reduced range of motion, particularly external rotation. There is no concern regarding neurovascular injury. Now, the question is, what is the most likely diagnosis in the patient? Rotator cuff tear, adhesive capsulitis, proximal humeral fracture, acromioclavicular joint dislocation, glenohumeral osteoarthritis. I'm just going to go back to the case so that you guys could read it on your own as well. And the poll should be coming up. Just give it a few more seconds for everyone to decide. All right. So let's go through the case. There's just a couple of things I wanted to mention. This question is a bit challenging in some sort of ways. It mentioned that the patient went to the urgent care to get it checked. So it's sort of we're assuming that they already made an ordered a shoulder scan and make sure that there was no fractures. And yeah, so before that, we go through the correct answer. The correct answer is adhesive capsulitis, frozen shoulder. Um, and the reason that is that if you go back to the case, the patient is having no pain at the moment, but just a problem with range of motion, particularly external rotation. Neurovascular is fine. There is no obvious swelling or deformity on palpation, which reduces likelihood of it being a fracture. Um, and the patient is diabetic and on insulin, which is a risk factor for frozen shoulder. So what is a frozen shoulder or adhesive capsulitis? It's an inflammatory condition of the shoulder capsule resulting in pain, contraction, and shoulder stiffness. It can present as an emergency with rapid onset of severe shoulder pain and restricted movement, and there may be an identifiable traumatic precipitant. And it may not always be like that. It may just be like that they have a shoulder pain and they can't move it, or it's frozen, or it's like a stiffness, and there's nothing that particularly triggered it. But in this case, there was a traumatic precipitant. Uh, a frozen shoulder following a significant injury, such as proximal humeral fracture, is termed as adhesive capsulitis. Typically, it has 3 stages. This is important. And then there is the first stage of freezing phase, 3 months, frozen phase for 6 months, and thawing phase for 12 months. And it eventually resolves spontaneously after many months or years. So what is freezing phase is there is an increased pain. It is worse at night. You may find it in questions. And the range of motion is restricted. The frozen phase, which usually takes around 6 months, is where the pain is less severe, but the movement is still very limited, particularly external rotation of the shoulder. And a thawing phase is basically the other name for things getting improved, where the pain eases and the range of motion is getting back to normal slowly. So the management of this adhesive capsulitis is with pain management and physiotherapy, usually NSAIDs, and yeah, you manage it with conservatively mostly. The other condition that may be similar is subacromial impingement, which is the most common cause of shoulder pain. It usually has an insidious onset, develops gradually, and exacerbated by overhead activities. Um, this is as a result of the compression of the rotator cuff muscles by superior structures, leading to inflammation and formation of bursitis. And this is a clinical diagnosis, and you may find a positive Neer or Hawkins test confirming subacromial impingement. And the treatment is again similar: NSAIDs, physical therapy, physiotherapy, maybe corticosteroid injections. Arthroscopic subacromial decompression is also available if conservative measurements fail. Now we have glenohumeral joint osteoarthritis that may present again similarly. It is more common in female patients. Incidence increases with age. The predominant symptoms are pain and stiffness, which lead to loss of function. What you may find is pain on palpation of the joint line. If it is severe, you may have restricted range of motion again, actively and passively. And with glenohumeral osteoarthritis, it's important to exclude other causes of stiffness like a frozen shoulder or locked steer dislocation. So you may want to order an X-ray to distinguish this condition or find whether it was traumatic, non-traumatic. And on X-ray, there are like classical findings that you may find. So a couple of things that you may find. This is a normal shoulder on the left-hand side. You can see that the joint space is normal. You can see the glenoid and humeral head. There's no sort of sclerosis, no particularly widening, no narrowing of the joint space. But on the right side where you have osteoarthritis, you can see that the joint space is narrowed. On the picture in the middle, you can see that the joint space is narrowed. On the right side, you can see that there's inferior osteophyte underneath the humeral head. So this is another finding of osteoarthritis in the shoulder joint. So the main findings are subchondral sclerosis, joint space narrowing, marginal osteophyte formation, and bone erosions. as like any sort of osteoarthritis anywhere else. The management with glenohumeral joint osteoarthritis, it depends. So primary care options are regular paracetamol or NSAIDs for pain control, physiotherapy for strength training, and you just advise patients on activity modification, and that's it. And there are some criteria where you may want to refer the patient to a shoulder specialist, and that's if the pain is severe, not controlled with above methods, the patient is significantly affected by the stiffness, and the diagnosis is not clear. And the secondary care options are steroid injections, arthroscopic debridement for a sort of a temporary relief of pain, and arthroplasty when the patient has significant pain or functional limitation.
I mean, there was
Now, we
a
have
sorry, there was a question in the chat. I don't know if you saw it.
no, I haven't. Just let me see. Adhesive capsulitis with rotator cuff. Would AC be painful in all range of motion, and the rotator cuff tear be worsened? So I'm not quite sure if I get the question. So adhesive capsulitis with rotator cuff, AC be painful in all range of motion, rotator cuff tear be worse on. I'm not quite sure. What we can do is we'll try to clarify that at the end if I haven't mentioned it. Is that okay? Or if you could just explain a bit more on what you mean, Sarah. Thank you. Um, so moving on to the rotator cuff tendinopathy, which may answer this question. So this is sort of recognized as part of a normal aging process, and the predominant symptoms are lateral shoulder pain and upper arm pain, pain aggravated by overhead activities, and weakness. Signs are painful arc, near sinus impingement, elicited. Can progress over time. Symptomatic tears are likely to increase in size, and over time, a torn rotator cuff may retract and become scarred, and the muscle bellies can be replaced by fat. At this stage is sort of known as irreversible. Um, so the thing with rotator cuff tendinopathy and cuff tear is that it's sort of considered as a sort of a spectrum. So with rotator cuff tear being at the end of the spectrum, um, and then which we will go through in a sec. Imaging findings often do not correlate with clinical findings. In many cases, evidence of rotator cuff tendinopathy can be seen in patients without symptoms. So we would still ask the patients if they have any symptoms. If not, then it's not very worrying. Um, and there is arthritis that can be resulted from rotator cuff disease and tears, and that's the rotator cuff arthropathy, which would show a different pattern of radiological changes to glenohumeral osteoarthritis. Uh, Just to mention that the blood flow in rotator cuff has been observed to decrease with age, and some parts of the rotator cuff, mainly around the insertion points, have been found to be hypovascular as we age, and that could sort of explain why we might get the rotator cuff tendinopathy. Now, moving on to shoulder anatomy, just put this as a recap, just to make sure we're all clear on the functions. So supraspinatus, the main action is abduction of the arm. Infraspinatus, the main action is external rotation, similar to teres minor, external rotation of the arm. And for subscapularis, we get internal rotation of the arm. And the nerves running it, you can see them here. Now moving on to rotator cuff tendinopathy investigation and management. Plain radiograph, X-ray to exclude other differentials, ultrasound scan to assess rotator cuff, and long head of biceps, MRI to assess rotator cuff. So I guess the first line would be, well, you do an X-ray to exclude everything else, such as joint osteoarthritis. And then if you still suspect the rotator cuff injury, you would get an ultrasound. The management is physiotherapy. You try to get the muscles strength high again with the physiotherapy uh, to make them strong again. We could have corticosteroids injections. Sorry, apologies. Corticosteroid injections or surgery. Rotator cuff plus minus arthroscopic subacromial decompression. And that's only if the inadequate response to non-operative management program is seen for about a year, which would include like 2 steroid injections. Then you would consider surgery. I'm just going to move on to the next question, rotator cuff arthropathy. A 78-year-old retired school teacher presents with progressive shoulder pain and limited range of motion. Over the past few years, she has a history of hypertension and diabetes, but is otherwise independent in daily activities. Imaging reveals cuff tear arthropathy with superior migration of humeral head and incompetent thoracoacromial arch despite degeneration. Despite the degeneration, her deltoid muscle remains intact. Considering her condition and functional status, what is the most appropriate treatment? So this question is a bit too complicated for medical students. I've just put it in for just out of interest. If anyone is interested, just learn a little bit more about what sort of surgery or surgical options are available for rotator cuff arthropathy. So we're going to have the poll. Just waiting for everyone to participate. Just going to give it a few more seconds. Now let's go back to it. So the correct answer is A, and we'll go through why. So cuff tear arthropathy is final stage of a severe rotator cuff damage. It happens when supraspinatus or other rotator cuff tendons tear, causing the humeral head to move upward and press against the acromion. Over time, this leads to joint degeneration. RTSA, reverse total shoulder arthroplasty, is best treatment because in this scenario, because it changes the mechanics of the shoulder, allowing the deltoid muscle to take over the function of the damaged rotator cuff, and this improves movements, especially arm elevation abductions. The key point to take away is that for RTSA to work, we need a intact deltoid muscle, since it will become the main mover of the shoulder after the surgery. And for a frail elderly patient who cannot undergo major surgery, arthroscopic debridement may be an option, but it doesn't really restore the function. So it's not the best option here. Now, I have included a slide on classifications of rotator cuff arthropathy. Again, you don't really have to know this, but the reason I've included it is that you guys could see like that how it is different to glenohumeral joint osteoarthritis in that the humeral head starts moving upward as there is a rotator cuff injury. The shoulder is less stabilized and the humeral head starts going upward, and that would sort of increases the frictions, and we will get a different pattern of basically arthropathy. Um, this is a slide on how our TSA would look like. So what is done is, if you imagine as sort of a socket and a yeah, socket and ball, if you could imagine, this is the humerus where we have sort of the socket here, and the bulb is here. Which on a normal anatomy would be the other way around. We would have the humeral head here, and there would be glenohumeral fossa uh, to which the head would sit. But here they would change it and reverse it, and that would give the patient basically the ability to move their arm. But it does come at the complication of this medial aspect of the implant damaging the skin or the neurovascular structures. And then we have another question, elbow pain. Sorry guys if it's too fast paced. We just have to go through a couple of questions and I'll make sure that we manage to complete all the conditions within 1 hour time frame. So I'm just going to move on to elbow pain. A 30-year-old male mechanic who has been working in the industry for several years presents to his GP complaining of right elbow pain that has been gradually worsening over the past few years. He mentions that the pain is particularly aggravated when performing tasks that require wrist flexion, such as gripping tools or lifting objects at work. He localizes the discomfort primarily to the inner medial side of the elbow joint. On examination, there is no visible swelling, bruising, or deformity of elbow. Palpation reveals tenderness that is localized over the medial epicondyle. There is no evidence of muscle wasting, and his range of motion remains largely preserved, though certain movements exacerbate his symptoms. Neurovascular examination performed and is normal. Normal sensation and normal circulation. The question is, what is the most likely diagnosis? Lateral epicondylitis, medial epicondylitis, cubital tunnel syndrome, and olecranon bursitis. So I'm just going to go back to the question. We will have the poll question in a sec. So essentially, there's a lot of information here. Just to summarize it, we have elbow pain, worse on wrist flexion and grabbing tools, and is on the medial aspect of the elbow. Yep, everyone has responded. So the correct answer is medial epicondylitis, golfer's elbow, which is caused by repetitive wrist flexion and forearm pronation, leading to pain again on the medial aspect, medial epicondyle. It's very common in manual workers and athletes. Um, and yeah, there's a table just summarizing the epicondylitis and the differences. So the location of the pain is on a medial epicondyle in medial epicondylitis, golfer's elbow, and yeah, that's one of the main things that would distinguish. And the way that I sort of remember the golfer's elbow is like if you imagine someone playing golf with their arm attached to their side to the body, and then that is sort of the arm is more medial. And then if you imagine someone playing tennis with arms outstretched like that, and the arm is sort of more lateral to the body. That's how I remember like the names. but I think usually it's given as medial epicondylitis or lateral epicondylitis anyways. And if you could imagine in medial epicondylitis, the wrist flexion and forearm pronation is affected. That's what causes the pain and makes it worse. And purely because of the muscle attachments, it involves the pronators. And so when we use these muscles, we will get the pain on the medial sides. And on the opposite side, on the lateral epicondylitis, is wrist extension and forearm supination that makes the pain worse. Both of them are usually caused by repetitive wrist movements, and examples are given. It's mainly a clinical diagnosis and based on history and examination, and you advise patient to rest, maybe do some physiotherapy, give some NSAIDs, painkillers, and advice on activity modification. So you basically just tell them to rest their arm for a bit. Um, and then we have tunnel syndromes. We have cubital tunnel syndrome and carpal tunnel syndrome, which we need to go through. Basically, it's a narrowing of the tunnel, the space that the nerves pass through, and the nerves and the tendons pass through. So in cubital tunnel syndrome, we get compression of ulnar nerve at the cubital tunnel at the elbow, and it gives a tingling numbness sensation in the fourth and fifth finger, which can start intermittently and then become more constant as it progresses. You may get weakness, muscle wasting in the thenar eminence. Pain worsens on elbow pressure, and it is sometimes associated with osteoarthritis or trauma. On the other side, with carpal tunnel syndrome, which is a compression of median nerve and a carpal tunnel, you get pain and pins and needle sensation in the thumb, index, and middle finger. So it's sort of a different distribution of median nerve, basically. Symptoms may ascend proximally. Shaking hands is sometimes known to relieve the pain. Uh, Weak thumb abduction, thin arm wrist wasting, positive tactile sign. These are the findings of the examination. I just mentioned for the cubital tunnel syndrome, we might get a wasting in hypothenar region, not the thenar region. So the investigation, this is a clinical diagnosis again, but you could do a nerve conduction study. And management-wise, what you do is you try not to do activities that would aggravate the pain. You would offer us physiotherapy, maybe some steroid injections if the initial measures did not help. And then for carpal tunnel syndrome, 6 week trial of conservative treatment, and then corticosteroid injection again. Uh, Sometimes wrist splint at night seem to help for some patients. And then if all of these didn't really work, what you could offer is surgical or referral for a surgical option. Surgical decompression would be a flexor retinaculum division where they release some space for the nerve and basically relieve the tension. Yeah, we have another question on hand stiffness. So a 65-year-old male carpenter presents to his GP with progressive stiffness in the right hand over the past year. He reports difficulty fully extending his ring and little finger. He denies pain but has noticed that his fingers appear permanently bent. He has a history of type 2 diabetes, consumes alcohol regularly. Father had similar issues. On examination, palpable nodule along the palmar fascia is noted, fixed flexion contracture on the ring and little finger, and inability to place his palm flat on the table. So he's the test positive. The question is, what is the most appropriate next step in the management? Just gonna give you a few seconds. Yeah, so I'm just going back to Sarah Moon and the question you asked. So you mentioned that whether the rotator cuff injuries are more specific to pain in external rotation, while adhesive capsulitis is more global pain in all shoulder movements, or are they similar? So the difference between acromioclavicular, AC and adhesive capsulitis and rotator cuff. So with rotator cuff injuries, pretty much depends on sort of which tendons are affected, and that would tell you when you would get the pain. With adhesive capsulitis, you would get a global pain, which so you basically have pain no matter what you do. You tend to not be able to move the shoulder at all because of the pain, and you would get a severe restriction again because of the pain. Whereas with rotator cuff injuries, you may be able to move it, but it's just very painful in particular movements. Again, depending on whether it is infraspinatus or teres minor, uh, pretty much depending on the tendon. Uh, the other difference between a rotator cuff injury and adhesive capsulitis is that in adhesive capsulitis, the passive and active range of motion are both restricted. So basically, the patient cannot move the arm, whereas in rotator cuff, the passive range of motion is usually okay. They may not be, if you think of it, they have a problem with their tendon, so they may not be able to move the arm, but you would be able to move it passively. So that shouldn't be causing pain or anything like that. Um, Yeah, but yeah, I hope that sort of answered the question. If not, I'm happy to clarify. So I'm just gonna go back to the question. We have here a 65-year-old male carpenter, progressive stiffness in the right hand, cannot fully extend the ring and little finger. So the correct answer is um, surgical intervention, and we will go through why that's the case. So this condition was a Dupuytren contracture, where you get progressive thickening of the palmar fascia. It has nothing to do with the tendons. Um, and this progressive thickening leads to fixed flexion deformity, mainly along the ring and little fingers. Yeah. And then it's more common in older male. A lot of them have family history of similar issues. And the other risk factors are manual labor, alcohol consumption, diabetes, phenytoin use, and hand trauma. Patients develop painless nodules that progress to contractures, making it difficult to place the hand flat on the table, and that's the Houston test positive. Um, the management is mainly surgical, where when the contractures impair the function, although there are like alternatives available, but they're not really the best option. So we tend to do operations on them. Um, the key things to remember with Dupuytren contracture is that there is no tenderness upon palpation. So the way you examine the patient is you just keep the hands like this, and then you go along the tendon. Um, you just feel along the tendons. There shouldn't be any tenderness. The sensations should be intact, and yeah, you may feel the nodules, and then you ask them to sort of close their wrist and then open it, and then you may see like they may not be able to do that. We have another similar sort of condition, trigger finger, which is commonly associated with abnormal flexion, which is common and is associated with abnormal flexion of the digits. Tendon becomes stuck and cannot pass smoothly through the pulley. More common in thumb, middle, and ring finger initially, and yeah, you may have a snapping uh, trigger when extending the flex digit. The management is steroid injections, and they're usually successful. Surgery again, if not, surgery is just reserved for the last case scenarios, like if the initial treatments wouldn't work. We have another case. Well, we don't have a case actually. This is just decorven tenosynovitis. So this is basically a condition affecting the sheath covering the extensor pollicis brevis and abductor pollicis longus tendons. And this sheath gets inflamed here over the radial aspect. It typically affects females aged 30 to 50. And the features on, again, as mentioned, pain on the radial side of the wrist, tenderness over the radial stylar process, and abduction of the thumb against resistant is painful. As you can imagine, it's sort of using the same muscle. So, and Finkelstein test is positive. Management is with analgesia, uh, adapting activities, steroid injections, immobilization of the thumb splint with with a splint to restrict the movement, and hopefully that should resolve the issue. If not, steroids, and then if not, surgical release of the sheath may help. And the surgical intervention is also called first dorsal compartment release, which involves releasing the fibrous sheath that constrains the APL and ABPL and APB, which is the which stands for the extensor pollicis brevis and abductor pollicis longus. So you release the sheath, relieve some pressure, and then that should resolve the issue. Now moving on some of the fractures we have. We're just going to quickly go through the different fractures of the upper limbs. So first we have a clavicle fracture. They're common fractures, usually from a direct blow or flow on the shoulder, fall on the shoulder. Deformity includes a lateral fragment decompression, the depression, and shortening with proximal displacement of medial fragments. The patient will be aware of the pain, and there may often be a crepitus on palpation at the fracture site, and this will usually the patient will usually be supporting their elbow with the other hand like this. So what you need to do is just to look at the area, see if there's any skin tethering, if there are skin changes, any spiking of the bone, any tenting, and whether the skin is at risk of being broken down. If not, well, you could get an X-ray as well, AP clavicle and 20-degree cephalad view. What you shouldn't do is attempt at close reduction. It's not usually recommended due to the risks to the surrounding neurovascular structures. And yeah, so what the management tends to be is usually supportive sling and just provide comfort, and the patient is still encouraged to use the elbow and wrist of the affected side. It's just try not to move the shoulder and the clavicles. There are some indications to have in mind. So indication for inpatient referral is where there is significant tenting, significant skin compromise, and neurovascular compromise. If there's any loss of sensations or things like that. And an indication for outpatient referral is basically all clavicle fractures should be referred to fracture clinic. Um, so that orthopedists could have a look at it. Indications for surgery include open fractures, where you get a skin breakdown or tenting, severe shortening of the arm, severe comminution, symptomatic non-union for the fractures that haven't healed at later stages. So usually the management is sort of conservative like, and then you put a sling, you arrange for a referral outpatient fracture clinic, and that's it. For proximal humeral fracture, they're commonly seen in females. They can result from low injury falls or high injury trauma in younger individuals, and they're associated with nerve injuries. The most commonly associated nerve injury is axillary nerve damage. It's not common to have arterial injury, but you may see in that case you might have some symptoms like expanding hematoma, things like that. Any swelling of the arm, you just have a look at it. And this tends to happen in older individuals, but again, it's not that common. How you investigate it is with complete trauma series, AP view, and another view at least. So two views needed at least, and a CT scan if you're planning for operation. The management is sling immobilization followed by rehab for most fractures. But if it's complex and if it's needed to have an operation, then you just refer them for operation. Operation. Sorry, I'll take some water. Next, we have humeral shaft fracture, and these are commonly associated with radial nerve palsy. As you can see, as you can imagine, the mid shaft. When you have a fracture in the mid shaft, the dislocation of the proximal and distal uh, parts can sort of press on the radial nerve, and that can give you radial nerve palsy, where you may get a wrist drop. Classified based on AO classification. Again, you need two views X-ray, and then this one has characteristics displacement depending on where the fracture is. So if your fracture is proximal to deltoid insertion, meaning that if it's a bit higher up, the proximal fragment is pulled into abduction by the action of pectoralis major and latissimus dorsi, and the lateral fragment goes the other way around. And if it is distal to the deltoid insertion, so the fracture is distal to the deltoid, what you see is that the proximal fragment is abducted by the deltoid. So if you can imagine the muscles insertions, so if you have basically fracture at further along the arm, distal to the deltoid insertion, um, what happens is that the deltoid is unopposed, sort of, and then that would put the initial part, so the more proximal part of the fracture, in a more abducted position, and you may find that the distal section is a bit more adducted. Whereas if the fracture was above the deltoid insertion, you would see this being other way around. Just the management is most fractures are treated without surgery by using a functional brace, and they generally heal around 9 weeks. If there's some indications, you may send the patient for operation, and these are open fractures where you get neurovascular compromise if there is a severe displacement, intra-articular fractures suspected, and segmental fractures. So again, the management was mostly conservative. With distal humeral fracture, this comprises of 1 to 2% of the fractures. Presentation is like we get elbow pain and swelling. On examination, what you need to do is to make sure that you check for open wounds, neurovascular compromise, and check range of motion. Think they have the sensations and everything is fine. And then you can order an X-ray, AP and lateral view, and then again the management and non-operative if minimal displacement, or if it is displaced but it is in an elderly and they're not really fit for a surgery. What you may do is just have a consultation with the patient and tell them that well, it may not be fit for the surgery and it may heal, but it may not heal. It may not go back to how it was in like a normal position. So you may have some sort of deformity left. And you may see this commonly in patients who have a fracture of the distal humeral who have a fracture of distal humerus, that you may see like it sort of isn't quite like how it should be. Basically, it's not like a normal anatomy. And then you have operation for almost all displaced distal humeral fractures. We have radial head and neck fracture. Common presentation to the ED is a radial head fracture. Mostly isolated, minimally displaced and stable, require symptomatic management. The way it presents is like with pain and tenderness along the lateral aspect of the elbow and limited supination and pronation. What you do have to do is to check for any other fractures or injuries, like Monteggia fracture, dislocation, or terrible triad injury. So what you always do with the orthopedic and MSK examination, you offer or you do examination of the joint above and below. And sometimes when you also request X-rays, you sort of have to get the joints above and below X-ray as well in the scan. Investigation is X-ray. Always thoroughly examine patient wrists to make sure there's nothing else is going on. And the management depends on fracture classification and how bad is the fracture. It is classified as in Mason criterias. If you want to have a look at later. But what you tend to do with the radial head fractures is you use sling for 2 to 4 weeks and NSAIDs, and that should resolve the issue. Patients should be advised to move their arm freely within the limits of comfort to prevent stiffness. It's important to remind them that while movement may be uncomfortable, it shouldn't cause any harm. Now we have olecranon fractures. They're common, resulting from direct fall on the elbow. Proximal fragment is often displaced proximally by the triceps muscle. Presentation is like you have a pain well localized to the posterior elbow. Upon palpation, you may find a palpable defect or inability to extend the elbow. Investigation again is with X-ray, AP, and lateral. Management is non-operative if there's no displacement and the extensor mechanisms, extensor muscles are intact. If there's some displacement or you think that the extensor mechanisms there's a loss of function, then you might have to operate on them. Now we have another case of wrist pain. A 22-year-old male university student presents to A&E with right wrist pain following on a fall on an outstretched hand while playing football. He reports immediate pain and swelling along the radial side of the wrist. He is otherwise well and has no previous wrist injury. On examination, tenderness over the anatomical snuff box, pain on longitudinal compression of the thumb, mild wrist effusion, no deformity or open wounds. Initial plain X-ray show no obvious fracture, but clinical suspicion remains high. So what is the most appropriate next step in the management of this patient? So I'm just going to go back to the questions. I think we get the poll questions. Poll questions coming up, yeah. Let's turn off the camera for a sec. Just going to give a few more seconds for everyone to put their answers through. So this is essentially a scaphoid fracture where you get a tenderness on anatomical snuff box here, um, and you would have some pain on the radial side. Now, the correct answer is B. Apply a below elbow thumb spica cast and arrange orthopedic follow-up in 7 to 10 days. And the reason for that is as you probably with a scaphoid fracture, they may not really show the X-ray may not show anything for a couple of days. We usually leave it for, I guess, 2 weeks, and then we get another X-ray to make sure that there hasn't been a fracture. And the reason for that is there is a high risk of avascular necrosis, as the blood supply to the scaphoid is sort of retrograde. So if you have a fracture, we may lose that blood supply, and then we would get avascular necrosis, and that would cause a lot of pain and discomfort in patient. So essentially, going through a scaphoid fracture, it's a common wrist fracture, usually due to you fall onto outstretched hand. Can be seen in contact sports or road traffic accidents. 80% of the blood supply is coming from dorsal carpal branch of the radial artery in a retrograde manner, and that's why there's a risk of avascular necrosis in a scaphoid fracture. So if we lose that blood supply, we would have a necrosis. Um, would manage how a scaphoid fracture presents is like pain at the base of the thumb, along with the radial side of the wrist, loss of grip and pinch strength. So what you do is you take history, you examine the patients, you check for anatomical stop box tenderness specifically. Now this has a high sensitivity, but low specificity, so it may show that it may tell you that there might be a scaphoid fracture, but it's not necessarily. It may not necessarily be a scaphoid fracture just causing the soft box tenderness. It may be something else, basically. You may get wrist effusion. You may have pain on the longitudinal compression of the thumb. Tenderness over the scaphoid tubercle. Pain on ulnar deviation of the wrist. Investigation again is X-ray, first line, 2 weeks after the event. And then if the X-ray is inconclusive, then you may also order an MRI. But essentially, you would have to leave it for 2 weeks and let the patient know of why you're doing that, so that they make sure that they attend their next X-ray. So the management with scaphoid fracture is immobilization with future splint or standard below elbow back slab. Clinical review within 7 to 10 days, it says here, but it may be like in 2 weeks um, for you to be able to see any X-ray changes. Definitive management, if undisplaced fracture, then well, it depends on whether it is displaced or undisplaced. If it is displaced, you would take them for surgical fixation. If it is undisplaced, you may not need surgery. The future explained may be okay. Complication is two main complications. We have avascular necrosis, as I mentioned, and non-union, which would again result in pain and early osteoarthritis. Now that's the end of my presentation. Sorry guys if it was a bit fast paced. If you guys have any questions, I'm happy to help. Just pop them in the chat or we just send them through later on.
Thank you, Almin. That was
Thank you very much.
yeah, very informative. We'll stay around for a couple of minutes for any questions. But thank you very much for listening. The feedback forms now should be available in the chat. So yeah, please fill that out.
Guys, yeah.
And also don't forget, so it'll also allow you to receive your certificate and discount codes for Teaching Me Surgery and pass the MRCS. And also be sure to complete the Google form, which I pasted into the chat as well, for a chance to win free access to the Geeky Medic surgical flashcards and their OSCE stations. The link is this, so the link should be in the chat now. Our next session will be on anatomy of the lower limb on Monday, the 24th of February at 6:30 p.m. Make sure to follow us on our social media platforms, and the links for this are available in the chat. You will be able to receive updates on those upcoming sessions via those platforms. We'll also be posting single best answer questions on our socials for additional practice, so keep an eye out for those. Don't forget to visit our website where you'll find a resource bank with materials not just for this session, but also all other sessions in this teaching series. These resources include summaries and a question bank featuring extra questions that aren't available on our social media. To access them, simply create a free account on our learning portal, and that should give you access. And we hope you found today's session valuable and engaging. Thank you once again for joining us, and we look forward to seeing you at our next session.